Hey, what's up everyone? Welcome to Asylums Uncovered, where we discuss the influence and impact of state hospitals on American history and the void left in their absence. If you're tuning into this episode and haven't watched part 1 yet, head over there to learn all about Dr. Walter Freeman. It's important for people to get an idea of who he was before listening to this episode about the lobotomy. The link for part 1 is in the description below, but I do want to mention again, if you're listening to the audio-only version, the video version might be better because the visuals really help make some of the information more digestible. What comes to mind when you hear the word lobotomy? For a lot of people, it might be an ice pick, because that's what's most often portrayed in movies or TV shows. But what actually was the lobotomy, and what was its purpose? In the 1930s, views on mental illness had changed and new treatments came out like insulin coma therapy and electroshock therapy. Academics were split whether mental illness was caused by a behavioral or a physical issue, and Dr. Walter Freeman believed the latter. He thought that surgery on the brain would alleviate mental illness, mostly for patients with mood disorders like anxiety or depression, not necessarily issues like schizophrenia, although that would change over time. The lobotomy was a surgery intended to treat mental illness by severing neural connections in the brain's frontal lobes. This part of the brain manages thoughts, personality, and emotions. It was believed that after the procedure, new neural pathways would form, alleviating mental illness. To put it simply, it was essentially rewiring the brain. Most people think that Freeman invented the lobotomy, but that's not entirely true. The process was adopted from surgeries that already existed, and Freeman just coined the term lobotomy and refined the procedure to make it his own. Years prior to the lobotomy, European doctors were already doing brain surgery on mentally ill patients, but Freeman would be most inspired by Portuguese neurologist Egas Moniz and his procedure called the leucotomy. And without this, I'm not sure if the lobotomy would have ever even existed. Once Freeman heard about the leucotomy, he was like, cool, I'm bringing this to the United States. Wanting to be as well respected in the medical field as his grandfather, Freeman was hellbent on making that happen. However, since he wasn't a surgeon, he couldn't just do the procedure himself in an operating room, so he solicited the assistance of neurosurgeon James Watts to help him. And I don't want to go into deep detail about Moniz or the leucotomy. I want to keep this more focused on Freeman, but it's important to understand what the leucotomy was so you know the procedure that Freeman was initially doing. He started out doing the leucotomy, then the prefrontal lobotomy, and then the transorbital lobotomy. The leucotomy was drilling holes in the skull above the prefrontal regions of the brain and inserting a tool that Moniz called the leucotome at different angles to sever the neural connections. The leucotome was a narrow shaft with a retractable wire loop at the end. And while this procedure was being done, the patient was under general anesthesia, so they were totally out while being operated on. One concern that Freeman and Watts initially had in doing this procedure was the ethics of a mentally ill patient consenting to surgery, and they agreed that either the patient themselves or a family member needed to consent on their behalf. But how could someone with mental illness truly understand what they were consenting to? And they did not discriminate in patient type. They operated on men, women, children, the elderly, but women made up most cases. Freeman thought that after surgery, it would be easier for a woman to return to normal as a homemaker versus a man with a career. Also, women made up most mood disorder cases, which Freeman believed would benefit best from the operation. In September 1936, Freeman and Watts performed their first leucotomy on 63-year-old Alice Hammett. Alice initially went to Freeman weeks prior for anxiety, depression, and insomnia, where he diagnosed her with agitated depression. And at this point in the 1930s, normally someone would be institutionalized to a state hospital, but Freeman offered another option. And this was the first time in American medical history that someone used surgery to cut the frontal lobes of the brain to treat a psychiatric disorder. This marks a huge, significant historical moment. The procedure lasted about an hour, and afterwards, Freeman declared the surgery a success, as Alice was eventually able to return to life as normal. During their second leucotomy, Freeman started photographing patients before and after surgery, and I had mentioned in part 1 of this episode that in his teenage years, he took quite quite an interest in photography, and thank God, because the records he left behind were pretty extraordinary. After completing 6 leucotomies in November of 1936, Freeman wanted to tell the masses that this procedure was the next big thing for the medical community. He presented their work at conferences and even got the press involved to write about how great this surgery was, even though they had mixed results. At a medical conference later that year, Freeman first used the term lobotomy as he presented their work, and this new term created by himself and Watts distinctly separated their work from Moniz, and thus the birth of the prefrontal lobotomy. The response to this presentation was mixed. They had both support and criticism. I'm sure you can imagine that not everyone was on board with operating on people's brains to treat a mental illness. One man who was supportive of Freeman and Watts was psychiatrist Adolf Meyer, and this held a lot of weight. Meyer was trained in neurology, worked at many different asylums, and was president of the American Psychiatric Association. He was on the forefront of integrating psychological and biological studies together, so having his support brought a lot of legitimacy to Freeman and Watts. The duo set a goal of completing 20 lobotomies by the end of that year, 1936. Out of these 20, 8 required a second lobotomy and 2 required a third. Now, keep in mind, the determination of who needed a second or third was purely subjective, and there was no empirical benchmark that needed to be met in order to say, you need a second lobotomy, you need a third lobotomy. Also keep in mind, although their process had the new name of lobotomy, at this time they were still using the original Moniz leucotome tool. Freeman and Watts refined their technique and tools. First, they replaced the wire loop at the end of the leucotome with a cutting blade for better precision. Then they relocated the entry holes from the top of the skull to the sides. And it was also at this time they stopped using the leucotome and replaced it with a tool called the Killian periosteal elevator. And this instrument allowed for even better precision and is still used today, mostly for nasal procedures, usually done by a plastic surgeon or an ENT surgeon. With the new location of the entry holes and the new tool, Freeman and Watts referred to this refined process as the precision method. They also had other methods known as the minimal lobotomy and the radical lobotomy. Minimal was for mood disorders like anxiety, depression, things like that, whereas the radical procedure was for more serious cases like schizophrenia. Around 1939, the duo started using local anesthesia before drilling the holes into the skull. So up until this point, patients were always under general anesthesia, but Freeman wanted to make the shift so he could ask patients questions throughout the surgery and determine which cuts were making the most impact. Even though they couldn't feel it, they were still fully awake and aware of what was happening. And I can't say I would want to be awake while getting brain surgery. If you've ever been to the dentist and you've gotten local anesthesia and you can hear the drilling and the crunching and all the horrible sounds, imagine that 100-fold while you're getting brain surgery. I can't even imagine. In the 1940s, the number of patients in mental asylums soared, and this was before chlorpromazine or thorazine hit the market and other antipsychotic medications came out. So the mentally ill were often institutionalized for life. Freeman claimed that he was disturbed that patients were warehoused, just left to deteriorate with no hope. And to him, the lobotomy seemed like the right answer to fix all of this. But did Freeman believe the procedure would actually help mentally ill patients, or did he see it more as an avenue for his own self-serving purposes? He proclaimed the lobotomy could return 60,000 patients to live normal, productive lives, and eventually he and Watts started doing the surgery on St. Elizabeth's Hospital patients. So remember, St. Elizabeth's was Freeman's former place of employment, and they did 80 lobotomies there over 7 years. Many other neurosurgeons and psychiatrists were also adopting the lobotomy for themselves. By the late 1940s, it had become mainstream. Some of the country's most prestigious institutions were allowing the procedure to include Johns Hopkins, Harvard, Yale, Mayo Clinic, and the VA, the Veterans Association, was doing about 48 lobotomies per month. Perhaps Freeman's most notable lobotomy patient was Rosemary Kennedy, the sister of President John F. Kennedy, and this case was an absolute utter failure. So growing up, Rosemary had intellectual difficulties and she was delayed in hitting developmental milestones. As a young adult, she suffered seizures and violent mood swings, and this resulted in her father forcing her to have a lobotomy in 1941 at 23 years old. And after the procedure, Rosemary's personality was forever changed. She was left physically disabled and lost her ability to speak. Unable to care for herself, she was sent to live at St. Coletta's School in Wisconsin in 1949. None of the Kennedy family visited her until almost a decade later. It was almost as if Rosemary was an embarrassment, and it was easier for them to just hide her away and forget about her. After more than a decade of performing the surgery, Freeman claimed only about 30% benefited from it, and almost 70% had no improvement or were worse off. 2% of those resulted in death from seizures, infection, or hemorrhaging. Now, remember, Freeman's out there saying the lobotomy is the next big thing for the medical community. We're gonna put 60,000 people back into society from the mental asylums. But here he's admitting 70% had no improvement or were worse off. I feel like this had to be a really big blow to Freeman, his ego, his work. Not good. Feeling like the lobotomy hadn't made the impact he thought it would, Freeman started to reflect and came to the conclusion that their current procedure was too damaging to patients. It left too many people with impairments and personality changes, and he started to question how the lobotomy could be further changed and improved. Up to this point, lobotomies were always performed in a controlled setting of an operating room with anesthesia and a neurosurgeon, but Freeman wanted to do the procedure in state hospitals, but due to budgeting, he knew this would be difficult. State hospitals were already so underfunded that allocating extra expenses for the appropriate sterile environment and surgeon was not going to happen. So he starts questioning, do we really need an operating room? Do we really need a surgeon? Freeman wanted to make the lobotomy simpler, easier, and cheaper. Then he remembered the work of Italian psychosurgeon Amaro Fiamberti, who instead of boring holes into the skull, he used the entrance of the eye socket to access the brain. And this was it for Freeman. He now found his new process that would be much quicker and wouldn't require a neurosurgeon or an operating room. And the transorbital lobotomy was born. Freeman believed this new process wouldn't change the patient's personality or have as negative side effects as the prefrontal lobotomy. He needed a tool that was strong enough to break the transorbital bone, and in his kitchen at home, he saw the perfect instrument, an ice pick. And with the tap of a hammer, it did the job just fine. In Freeman's eyes, the transorbital lobotomy was now the quick fix for state hospital patients. In fact, he claimed it would take just 7 minutes. Psychiatrists with zero surgical training could perform the procedure right in their office. So Freeman has now taken the lobotomy from lasting hours in a sterile operating room with a surgeon to an office with someone not even trained in surgery. And it gets better. Instead of using traditional anesthesia, which wasn't readily available in state hospitals, Freeman used electroshock therapy to just render the patient unconscious. Electroshock doesn't just administer little buzzes to the brain, it produces violent convulsions that often broke bones. The first 10 transorbital lobotomies were not state hospital patients, but consenting participants that underwent the procedure in Freeman's office beginning in 1946. The first 9 procedures were done only by Freeman, and on the 10th, he asked Watts to come observe. Watts claims he walked in mid-surgery while an ice pick is sticking out of the patient's eye socket, and Freeman just nonchalantly asks him to hold it so he can take a photo, and Watts wanted nothing to do with it. As a neurosurgeon, Watts was very conservative by the book and took sterilization very seriously, and seeing this procedure done in an office, not an operating room, set him off, and this was the start of a rift between him and Freeman. The following year was the straw that broke the camel's back when Freeman was teaching psychiatrists to do the lobotomy, but don't worry, the duo eventually rekindled their friendship, and they're just such an odd pair. They couldn't be any more different, but they seem so codependent on each other. And just to be clear, Watts was never against the procedure. He was against the conditions in which it was being administered, which is a valid point. He did perform his own lobotomies, mostly on schizophrenic patients, but always always in an operating room. Freeman traveled across the country to state hospitals teaching psychiatrists, not surgeons, to perform the procedure. In fact, these institutions were begging him to come demonstrate. And Freeman was loving this. He was finally getting the attention, the notoriety, and the respect he felt he deserved. Eventually, he went to 55 hospitals in 23 states. And sorry to bust a common myth out there, no, he did not refer to his vehicle as the Lobotomobile, which is often reported, but it's not true. But not everyone along the way was on board. Some state hospital staff reported Freeman was almost like a circus act, operating in both eyes at the same time while smiling, almost like a look at me, look what I can do kind of attitude. It was very odd, but this goes back to Freeman being a showman and loving the attention. By this time, both Freeman and Watts had mixed results. However, fewer transorbital patients died or were permanently disabled than those who underwent a prefrontal lobotomy. According to Freeman, 45% of his transorbital patients living in a state hospital were able to return home. 80% of schizophrenic patients and 90% with depression were discharged within 6 months after surgery. Now, these were Freeman's numbers. Other studies show that the lobotomy was a failure and didn't have any impact on state hospital discharges, but he claims those numbers were false. So do your own research and decide on your own what to believe. By the end of 1948, Freeman yet again updated his technique. He used the deep frontal cut for patients who didn't get better after receiving a traditional transorbital lobotomy. And with this refined procedure came new hardware, an ice pick made of steel that Freeman called the orbitoclast. He needed a stronger tool because with the deeper cut, the regular ice pick would often break off into the patient's brain. As his popularity skyrocketed, his judgment seemed to plummet. In 1950, a patient failed to show up for his lobotomy 3 times, and Freeman was contacted that police were holding the man in custody at a motel in Bethesda, Maryland after a disturbance. Freeman drives to the hotel, and after this man's brother gave consent, the police held the man down while Freeman administered electroshock and then a transorbital lobotomy, all within the matter of minutes. I can't even begin to imagine how traumatizing that was. The following year, Freeman again hit the road to travel across the country to perform and teach the lobotomy. While at Cherokee State Hospital in Iowa, which is a Kirkbride, he accidentally killed a patient because the ice pick slid too deep into the patient's brain while he stopped to take photos. West Virginia started a large state hospital transorbital lobotomy program in 1952. 228 patients were operated on over 12 days. At Spencer State Hospital, Freeman did 25 lobotomies in 1 day, and I don't believe this record was ever beat. After the procedure, 36% were released from a state hospital, and Freeman declared this project a big success. According to the biography, the book written about Freeman, The Lobotomist, Freeman devoted an intensity and energy to his mission in West Virginia that he surpassed nowhere else. Over the next 4 years, he frequently visited the state, with the result that its per capita rate of lobotomy was the highest in the nation. And if you ever visit Trans-Allegheny in West Virginia, they have a very cool room set up all about Freeman and the lobotomy, and you can really learn more about the West Virginia transorbital lobotomy project. During this large-scale lobotomy project, the CIA, the Central Intelligence Agency, sent a psychiatrist on a secret investigation to observe the lobotomy and report on how they could possibly use it. Ultimately, it was determined that the lobotomy wasn't a procedure that they could use because it had way too many risks, but who really knows? I mean, the CIA was doing way worse things. Like, hello, MK Ultra, anyone? 1954 was a game changer for psychiatric treatment as Thorazine hit the market. This antipsychotic medication, mainly used for bipolar disorder and schizophrenia, allowed patients to take the medicine, live at home, and function in society. They no longer needed to be institutionalized in a state hospital. Thorazine was doing what Freeman wanted the lobotomy to do, and soon the prominence of the lobotomy started to fade. During the summer of 1954, Freeman and his wife Marjorie moved from Washington, D.C. to the Bay Area of California. Finding work there initially was really difficult. Freeman was seen as a black sheep. He was referred to as the ice pick lobotomist. So he opened a private practice and continued to do lobotomies for the rest of his career, as the Herrick Memorial Hospital in Berkeley granted him full surgical privileges. Again, Freeman wasn't a surgeon. Why are we giving him full surgical privileges? It doesn't make any sense. Out of his California patients, a young boy named Howard Dulley would be the most notable. Dulley was forced by his father and stepmother to get a lobotomy at the age of 12. Dulley wrote a book called My Lobotomy, and it is fascinating. If you haven't read this book, go purchase it right now and read it. He talks all about getting a lobotomy at age 12 and being institutionalized in Agnew State Hospital. It's a great book. I highly recommend. One thing that was always important to Freeman was catching up with his former patients. He would drive all over the country to visit them and keep record of how they were doing. He would soon accumulate the world's largest database of psychosurgery cases, which is pretty incredible, honestly. Freeman performed his last transorbital lobotomy at Herrick Memorial Hospital in February 1967 at 72 years old. And I can't imagine what he was feeling. His work was his entire identity, so who was he now without it? After receiving a cancer diagnosis, Freeman sold his house, closed his private practice, and bought an RV with the plan to travel around and connect with more of his former lobotomy patients. In this odd way, he finally felt free. Freeman passed away from cancer on May 31st, 1972 at the age of 76. Most of his records were donated to George Washington University, where they currently live in the archives. Out of the almost 50,000 lobotomy procedures done in the United States, Freeman was responsible for 3,500 of them. I hope through these two episodes, it brought a human element to the lobotomy. Oftentimes in pop culture, it's kind of joked about, but for a lot of people, this was their reality, sometimes against their will. Right, wrong, or indifferent, Freeman will remain an infamous medical figure. And that's it for me today. Thanks for listening, and until next time.